Hello everyone, this is Dr. Priyadarshini, one of the mentors at StudyEFOG, and today we are going to discuss for the RRR series on the topic urogynecology. So some important topics to remember under this module are about urinary incontinence, the types, the management, the surgery options for all, pelvic organ prolapse, how do you quantify, how do you classify, and how do you manage, a special mention about vault prolapse, treatment of UTIs, recurrent UTIs, injuries, especially the bladder and the ureter injuries, and also a bit about bladder pain syndrome. So, coming to urinary incontinence, what can be the clinical presentation like? A woman can present with any of the lower urinary tract symptoms. So, at the first evaluation, we need to take a proper history and do a physical examination. So, we have to categorize whether the urinary incontinence is of stress, urge, or mixed type. So, based on the initial history taking, the examination or the follow up is going to continue. Now, if stress, then we are going to talk to her about the various options we have. And so, if it is urge, again, we're going to talk to her about the options we have for her. We need to mention also about bladder diaries. What is the use of it and how is she supposed to maintain? And not to forget, this has to be maintained at least for a minimum of 3 days. The need of specialist referral depends on other factors like if there is any predisposing factors, precipitating factors, or any other differential diagnosis that we can think about. How about doing a urine dipstick? Now, urine testing is essential to rule out UTI because UTI can also present with the same symptoms of urinary incontinence. Now, whenever there is any complications associated, like a case of recurrent incontinence or associated with severe pain or hematuria or severe pelvic irradiation in the past, that means we need to refer the women immediately. Suppose if there is any other symptoms associated, like a post void residual volume is detected, or there is any pelvic mass, again that warrants a referral to specialist. So, for urinary incontinence, what is going to be the initial clinical management like, and how are we going to categorize? So, categorization depends on the symptom that the woman is going to present to us with, and predisposing and respirating factors should not be missed. Always not to forget a digital examination. This is needed before advising the women for a supervised pelvic floor muscle training. So, what if the woman has a mixed urinary incontinence? So, whenever there is mixed urinary incontinence, we need to treat the predominant symptom, whether it is urge or whether it is stress, that has to be assessed and treatment needs to be provided. So, urine testing, what is the importance of doing? Dipstick and UTI symptoms, if the dipstick is positive or negative. Okay, depending on that, we are going to go into the next step of having a culture. Okay, now whether the culture is going to show us some growth or not show us some growth. Whenever there is growth, then of course we are going to give her some kind of antibiotics for relief of her infection. Now, whenever we're doing this dipstick, we'll have to correlate it clinically with whether the woman has got symptoms or no. Now, coming to the various types of urinary incontinence, the predominant ones that we will be dealing with is about the stress and the urge urinary incontinence. Now, what is stress? Whenever there is an increase in the intra-abdominal pressure, say for example, chronic cough, or exertion, then the woman is going to have some leak. This is called as stress urinary incontinence. The most possible reason for this is going to be a very weak pelvic floor, and a classical example being that of following a childbirth. Coming to urge, in urge, there's a sudden urge to void, and there can be increase in the frequency of micturition, and there is leak associated. In mixed, what happens? We have both the types of or both the symptoms of both stress and urge. However, one can be predominant over the other. Now, when we come to the conclusion of an urinary incontinence or an overactive bladder, what are we going to do? The main symptoms are going to be that of increase in the urgency, frequency, nocturia. It can sometimes even be associated with stress when we are dealing with a mixed urinary incontinence. So we are going to start with basic lifestyle modification, change in the diet, change in the fluid, restrict the use of caffeine, BMI management. Of course, a lesser BMI is going to aid us in better treatment options, and also regularizing the bowel. Now, what are the main drugs we have in the management of urge incontinence? Is going to be our antimuscarinics and beta 3 adrenoceptor agonist. Now, behavioral therapy for these kind of urgency urinary incontinence is going to be bladder training, suppression techniques, and pelvic floor muscle training. Now, again, we need to reassess once we put her on lifestyle modifications and behavioral treatment. If she is going to get better, then of course we are going to have a follow up for her. Now, what if the woman is refractory or not responding to any of this? Then we think about secondary options like botulinum toxins, neuromodulation, or nerve stimulations. At last, if nothing is going to work out for her, then we give her options of surgery like augmentation cystoplasty. Now, this is a simple example of a botulinum toxin, how it's being injected. Now, you see a cystoscopy is being done, and through the needle, there are multiple spots of Botox that's been injected throughout the bladder. These images, I've just made it so that, the presentation becomes a little interesting. Now, what if we have a woman with stress urinary incontinence? The initial assessment with the clinical history and the examination, we are going to assess her the severity of stress incontinence and how much is the quality of life that's being affected. Now, whether this is associated with a pelvic organ prolapse or no needs to be excluded. Why? Because again, the treatment options are going to vary, and we will discuss it later on. Now, if suppose if she has not got any kind of pelvic organ prolapse, then we are going to offer her conservative management with or without containment. Again, we'll have to see the type, mixed, urge, or is it purely stress? For stress, we are going to advocate her with some pelvic floor muscle education and some drugs added on if it is not helping her. If it is success, then we are going to complete the course. If no, then we have to refer her to some secondary care. But if the woman on the initial evaluation has a symptomatic pelvic organ prolapse, well, that warrants us to refer her to a secondary care. Now, coming to pelvic floor muscle exercise, how much we are going to advise her? 3 months, 8 contractions for 3 times a day. Now, for stress urinary incontinence, as I mentioned, the first line is going to be pelvic floor muscle training. The second line, we can offer her some drugs like duloxetine, which is an SNRI. This is considered as an alternative to surgical management. Now, surgical management is the mainstay of treatment for cases of stress urinary incontinence. The cure rate with these surgeries are almost 90%, so it's very effective. So, what are the types of surgery we can advise a woman with? We have various surgeries like colposuspension, which can either be done laparoscopically or open, autologous facial sling surgeries, retropubic midurethral mesh sling surgeries, or intramural bulking agents. Now, whenever a woman undergoes these kind of surgeries, she needs to be assessed within 6 months to see how she's coping up with the stress urinary incontinence. Now, going on to the various surgical modalities, the first one we will talk to is about the Birch Colpo suspension. In Birch Colpo suspension, what we do, we are going to elevate the bladder neck and support it. So this is going to correct the stress urinary incontinence and also any underlying cystocele if present. So the bird sutures can be placed either laparoscopically or open method. What is the difference between both? Laparoscopy basically is going to take a longer time, less blood, but the women can get back to her activities very normal. So in a well expertised hand, laparoscopy is always suitable. However, the first modality can be considered as an open Birch Colpo suspension. Now, what are the various complications that a woman can encounter with this surgery? There can be some voiding difficulties, which usually resolves in some time. There can be, if overdone, can be associated with urgency or urge incontinence. Coming to second type of surgeries is offering the women with slings. So these slings are usually placed in the mid-urethral region. We can either have a transvaginal tape or there can be a transobturator tape. The main disadvantage of using them are the mesh erosion that can be associated with this sling. Now, this is a classical example of how a TVT or a TOT procedure is done. TVT stands for transvaginal tape and TOT is for transobturator tape. For TVT, we are not going to use the obturator route. We are going to use the retropubic space and the bladder neck is suspended. Whereas in TOT, O stands for obturator. So the mesh is passed via the obturator foramen and the bladder neck is getting suspended. Now, this is an example of bulking agents. So these intramural bulking agents are injected at the neck so that there is a seal which is produced. So this seal is going to prevent the leak of urine. This is done under the aid of a cystoscope. So after understanding the various type of incontinence, we also need to understand the urodynamic chart, how the urodynamic studies are done and how do we interpret this urodynamic graphs. This is considered an important part of urogynecology from the exam point of view. Now, urodynamic graphs are graphs that is going to help us understand the various pressure changes that takes place within the bladder. For this basic thing, basically we have the filling phase and the voiding phase. In filling phase, what happens, we're going to read the pressure changes that takes place in the bladder, and in voiding phase we're going to make the women empty the bladder and see for the flow of urine. So where are the pressure gauges we are going to keep? One is going to be placed in the rectum, which is going to measure the intra-abdominal pressure, and the other one is in the bladder. So this stands for P-abd and P-ves. P-det is basically the dead-to-sub pressure, which we are just going to have by subtracting the P-abd and P-ves. So these tracings will be taken from the women, and these tracings are going to give us an idea about the urodynamic incontinence the woman is going to have. So this is an example. We have the filling phase and we have the voiding phase. So if we observe, the first one stands for P-ves, which is nothing but the vesical pressure or the pressure inside the bladder. The P-abd stands for the abdominal pressure, which where the probe is placed in the rectum. We understand that whenever the woman coughs, there is also an increase or a change in the vesicular pressure. P-det is nothing but the dead to sub pressure. So after the filling phase, we see in filling phase everything is quiet, the bladder is quiet, and in the voiding phase the pressure increases. Why? Because only if the pressure increases there can be passage of urine. So another important concept or topic to remember in urodynamics is about pelvic organ prolapse. So the women can present with symptoms of prolapse. So she can come with a mass descending per vagina, or there can be some other symptoms of urinary or bowel or some difficulty in the sexual life. On examination, we are going to look for the pelvic organ prolapse. Most importantly, we need to understand how we are going to make the POPQ grid, because the POPQ grid is the basis of for us to identify the kind of prolapse or the type of prolapse so that the treatment can be customized for that. So the degree of prolapse is going to be classified with the POPQ, and we're going to assess also the activity of the pelvic floor muscles. And not to forget vaginal atrophy, we'll have to assess and see if she needs any treatment for the same. So this is an example of a POPQ grid. A POPQ grid is basically having 9 small boxes, and we have the anterior, which is represented by small a, posterior, which is represented by small p. Now in anterior, again, we have 3, AA, BA and C. And in posterior, we have AP, BP and D. C is for cervix and D is for vault. In cases of post-hysterectomy patients, it is nothing but the posterior fornix or the vault. It refers to the vault. So in the middle, again, we have 3 more boxes, which is going to represent the genital hiatus, the perineal body, and the total vaginal length. The total vaginal length is the only measurement that's taken at rest. Rest all, we're going to tell the women to strain and measure for the same. So, depending on what we have in our grid, we are going to stage the pelvic organ prolapse. So this staging is stage 0 when there is absolutely no prolapse, stage 1 where the most distal portion of the prolapse is more than 1 centimeter above the level of hymen. So hymen plays a vital role. So hymen is the marking point via which we are going to stage the pelvic organ prolapse. So more than 1 centimeter above hymen is stage 1. 1 centimeter just above or below the hymen is stage 2. And stage 3 is more than 1 centimeter below the hymen, but not more than 2 centimeters. And stage 4, there is a complete vaginal eversion. So what are we going to do for these kind of women with prolapse? We are going to start with lifestyle modification, reduction in weight, reduction in BMI plays a very vital role. Heavy lifting, so activities that are going to increase the pressure has to be restricted. And use of topical estrogen, especially if the woman has vaginal atrophy, is going to help her. Pelvic floor muscle training we need to give her for a minimum of 4 months. So this is beneficial in stage 1 and 2 of prolapse. So if the woman finds it useful to her, she might well as continue on the same. The second modality is the use of pessary. If the woman is doing the exercise and she finds it useful, the add-on therapy for her can be the use of pessary. Now, before pessary, the most important ones are vaginal atrophy has to be taken care of by using some topical estrogen, and we have to tell her it is a trial and error, so the appropriate size has to be chosen for her. Affecting the sexual life, complications like discharge, bleeding has to be informed to her. So every 6 months we need to remove the pessary and reinsert it. So this is an example of the various types of pessary. The most common ones are the round, the cube, the gel horn pessaries. These are very, very commonly used. So if this is also tried and still the woman is not getting relieved, then of course the definitive management is going to be surgical management. Now, what are the surgical options we have? We can either offer a vaginal hysterectomy with or without a sacrospinous fixation, or if she want to conserve her uterus, she can go for a sacrospinous hysterospexy with the sutures and a Manchester repair. Colpoclesis. Now, what is colpoclesis? If we have a very old woman who's not interested in any sexual activity, or if she has any comorbidities to do a major surgical procedure, then we do her colpoclesis. Now, colpoclesis is basically suturing the anterior and posterior vaginal walls together. So what are the surgical options we have for an anterior prolapse? Again, it can be surgical or non-surgical. The repair can be done without mesh because we have the bladder down below, and any mesh erosion is going to go directly into the bladder and cause a lot of complications. Posterior prolapse, again, the repair can be done without mesh. We have the bowel there. So mesh erosion plays a vital role in deciding the kind of surgical management and whether not or to use a mesh. The follow up is going to be every 6 months. We are going to do a vaginal examination to see how good the prolapse is, whether she is completely cured of it, or whether there is any recurrent symptoms or complications. Especially mesh erosion is not to be forgotten. Now, what do we do if we have a woman who's got a pelvic organ prolapse along with a stress urinary incontinence? You're not going to offer surgery to prevent incontinence in a woman who's going to have surgery for a prolapse who doesn't have incontinence. So treat what the woman has. An anterior or an apical prolapse without stress urinary incontinence has a risk of developing this urinary incontinence in the post-op period. If the woman has an anterior or an apical prolapse along with a stress urinary incontinence, then only we are going to do a concurrent surgery. And we also need to explain that there can be some uncertainty. So combined procedure is of course effective for treating beyond 1 year. However, this stress urinary incontinence might persist despite surgery. So counseling is very, very important. Uh, Learning a bit about post-hysterectomy vault prolapse. Now, what happens following hysterectomy? The vaginal cuff or the vault can drop down, causing a prolapse. So, in POPQ staging, the point C is where the the cervix is, or the scar is going to be present at point C. Now, what are the chances of this? After hysterectomy, it is almost 11.6% if the hysterectomy was done for a prolapse, or if the hysterectomy was done for any other benign condition, it is almost 1.8%. Again, we are going to assess the women, standardize and do a classification system and see whether her quality of life is affected or not. So the management options can either be conservative, like the use of pessaries and pelvic floor muscle training, or we can offer her a surgical management. The surgical procedures that we can offer these women are basically two different types. One is the abdominal sacrocolpopexy, the other one is the sacrospinous fixation. Now, both are very effective in the cases of post-hysterectomy vault prolapse. Now, the advantages and disadvantages among both: in abdominal sacrocolpopexy, there is a lower rate of recurrent cases of vault prolapse. There's lower rate of dyspareunia and lower rate of post-op SUI. So, for a woman who is sexually active, an abdominal sacrocolpopexy is more effective. In sacrospinous fixation, what happens? The vault is getting fixed to the sacrospinous ligament. So there can be shortening of the vagina. So the sexual life can be affected. The success rate is almost 78 to 100%. However, not to forget, there can be chances of mesh erosion also. The serious complication with the sacrospinous fixation can be injury to the bowel, bleeding, and sacral myelitis. Now, these are examples or pictures of sacrocolpopexy. So, in sacrocolpopexy, if you see, the vault is getting fixed to the sacral promontory with a mesh. In sacrospinous fixation, we are going to suture the walls of the vagina or the vault to the sacrospinous ligament. This can either be done unilateral or bilateral. So these are some basic surgical procedures and some basic understanding of some of the topics of this module. Now let's see what kind of questions we can expect in this module. So going to an AMQ, we have the clinical scenario and we are going to choose the single most suitable investigations. So let's look into the question. We have Mrs. Bradley, a 45-year-old woman, para 2 living 2, who's going to present with leaking of urine while coughing, sneezing, exercising, and occasionally difficulty in voiding, previous to vaginal deliveries, recent diagnosis of hypertension, which is well under control. So she has tried her pelvic floor exercise with little improvement, but now she wants a definitive treatment. There's minimal prolapse, urine analysis is normal. So all the basic investigations have been done. Let's see what is going to be the most suitable investigations. So examination is done. That's how we get prolapse. Urine analysis has also been done. So with the symptoms and the first line, we'll have to go and do a urodynamic study. Now, why are we going on with urodynamic study? Because she has already tried the conservative measures, but now she wants a definitive treatment. So, whenever the women with a history of stress incontinence who has avoiding dysfunction also, we need to do a urodynamic study before undertaking surgery. That is the reason we are going with a urodynamic study here. So, what are the indications for doing urodynamic study before a surgery for stress urinary incontinence? If the woman has an urge predominant mixed incontinence, or you're not sure of the type of urinary incontinence, or there is symptoms that is suggestive of avoiding dysfunction, as in this case, or there's a prolapse, especially an anterior or an apical prolapse, or the woman has already been operated once for stress urinary incontinence, we need to do a urodynamic study. We have the second question. We have Mrs. S, who is a 56-year-old lady who presents with symptoms of urgency and urge incontinence, and there's difficulty in passing of urine on and off. She has had previous 3 normal vaginal deliveries and now the urine analysis is also clear. So we have symptoms of urgency. So we're thinking in terms of urge incontinence. The first test, that is the urine analysis, is clear. So what next are we going to do? We are going to measure for a post-void residual urine. Now, why are we going to do this? Because measurement of this or by either a scan or catheterization is important because the symptoms is suggestive of avoiding dysfunction, or it can be a case of recurrent UTI because difficulty in passing urine on and off. So measuring this and only then proceeding on with the treatment of urinary incontinence, that is urge urinary incontinence, is warranted. We have another scenario. We have Mrs. Henry, who's a 60-year-old woman, parent to living two, who presents with symptoms of frequency, urgency, and urgency incontinence. She also has incontinence with coughing and sneezing. So we see both the types are present. She feels that her bladder does not completely empty when she urinates. So, what is the most appropriate option of investigating her symptom? So, basically, she has both the symptoms of urge and stress, and she also has incomplete emptying of bladder. So, a bladder diary is necessary for her. Why? Because we have to first understand the kind of incontinence she have. Okay, so we have to tell her to wait for the 3 days, minimum of 3 days, and she's going to have a bladder diary covering her variations in her usual day-to-day activities, like in the both working and leisure days, so that we have a clear understanding of what's happening with her. So, going to some SBAs, we have a 54-year-old woman who has had wall prolapse following a vaginal hysterectomy 5 years back. So, it is a case of post hysterectomy wall prolapse. She is an entrepreneur and is very fit and fine. She's sexually active and has recently started on with a new relationship. What's the most appropriate surgical management for her? So, sexually active women with wall prolapse, I will go in for a sacrocolpopexy. We have Mrs. Whitefield, a 56-year-old multiparous woman with history of stress urinary incontinence. And now the treatment option that's being considered is a mid-urethral sling procedure based on her choices. Now, what is the type of mesh that is being used in this? So this is a direct theory question, and it is macroporous polypropylene type 1 mesh that we are using in cases of transvaginal tapes. So it is type 1 macroporous polypropylene mesh. So coming to some interesting urodynamic graph, let's decode the urodynamic graphs. We have this question. So we need to identify what is the diagnosis from the graph. We do not have any other information. This is just to make you all understand the urodynamic graph. However, in exam, you can have a scenario followed by a graph also. So the first line that's in blue, which is representative of the P West, and second one is P abd in red, and the third one is in green, which is P detrusor. Now we find that abdomen pressure, there is whenever there's there's an increase in the vesical pressure. However, there's no leak. But if whenever there's an increase in the detrusor and vesicle together, and there's a leak, again there's a second leak with an increase in the detrusor and the vesicle pressure. Okay, so this is a classical example of a urodynamic urinary incontinence. Now, coming to the second question. In second question again, the first one, the blue one, is P vesicle. The second one is P abdominal, and the third one is P detrusor. Now, what we observe in the first glance is the detrusor is completely silent. There's no changes in the detrusor. Whereas whenever there's a change in the abdominal pressure, it is also reflecting in the vesical pressure, which again is a normal finding. However, if we observe if there is any leak throughout the procedure, there is no leak except for in the voiding phase, which is again a normal finding. So this kind of graphical representation of a change in abdominal pressure reflecting in the vesical pressure, the detrusor being completely normal with no leak, is suggestive of a normal urodynamic graph. So this question, we have changes in the vesical pressure, abdominal pressure, detrusor. If you see the last line is completely silent without any pressure changes. So whenever there's a change in abdomen pressure, it is reflecting in the vesicle associated with a leak. So this is a classical example or a picture of stress urinary incontinence. So the first one is a detrusor overactivity. Remember, whenever we have a urodynamic urge incontinence, it is labeled as detrusor overactivity. The second one, the second graph that I showed was a normal study, and the last one was a case of stress incontinence. Again, a direct question. What is the mode of action of duloxetine? Now we see duloxetine as a drug that is used in the management of urinary incontinence. So understanding the basic drugs and the mechanism of action is very important. So duloxetine is a serotonin noradrenaline uptake inhibitor. So, thank you everyone for your patient listening to this urodynamic module. Do subscribe to our YouTube channel. There are more and more videos which are going to help you for a very quick revision before the exams. Thank you and happy learning.